Hi everyone, this is Mimi Niles. I am happy to be with all of you there in spirit, presenting today on the idea of reproductive inequities and looking specifically at maternal morbidity and mortality. Hopefully, my talk with you today will build on the concepts that you're reviewing today in class, which are really critical concepts related to health disparity, health equity, and really moving the dial on some of these really critical issues that are impacting certain populations of people. So for those of you who don't know me, maybe you've seen me around, I'm also a student here. I'm also a practicing midwife. I work at a city hospital in Brooklyn, and I am a PhD student. My research area is looking at the public health midwifery workforce here in New York City and how we function in particular locations and how we work with certain populations, applying the midwifery model of care. And I also have a degree in public health, and my concentration was in global health leadership. So you definitely will have a little of that flavor of global topics coming through this lecture as well. I hope that we can really dig into some of these ideas as much as we're able to in our limited time, and really look at the issues related to maternal health, which have really been exposed lately, just the abysmal quality that we have here in the US related to our maternal health outcomes, and talk a little bit about morbidity and mortality, which are both growing concerns, both in the US and in New York City. Look a little bit at what are some of the causes and conditions through the disparity lens, through the social determinants of health lens, and also consider towards the end of the talk what are some ideas for improvement, what are some areas that we can rally around as providers and for all of you as future nurses. So I'm sorry that I'm actually not there with you in my physical form, but interestingly enough, I sit on the New York City Department of Health Maternal Morbidity and Mortality Review Board. I was appointed to the board, and today we review cases. So we actually, in New York City, have a newly formed board where we review cases of maternal death that happen throughout the city. It's a really interesting process. New York City is not new to the process, so we're not innovative in conducting these review boards. But this is a brand new review board that's an interdisciplinary board, and that is innovative. So I'm there with you in spirit, and just wanting you to know that the work is happening. So it's really, I'm really happy that Dr. Crespo asked me to present on this. And I do want to frame my work with full exposure on who I am as a provider. I think it's important that we sort of reveal our own biases when we do this kind of work. And I truly believe that for real, true change to happen in this area of health and human rights, that we need to really begin to truly and deeply, authentically empower the rights of women and families. Because without that, I don't know if true change will truly happen. So also building on some theoretical frameworks, I remember as a nursing student really being somewhat annoyed and pensive about theoretical frameworks. I really wasn't sure how it would apply to my bedside clinical practice, but now as a doctoral student, I think I've sort of swallowed the pill and really value theoretical frameworks, because I think what they do is they allow our thinking to be informed by bigger bodies of work, and it allows us to frame our thinking in a more systematic way. And there are some theories that already exist that probably unify with your vision of how you see the world and how you see healthcare. So this lecture builds on these theoretical frameworks. I just want to be really clear about that. Critical feminist theory, critical race theory. I know you spoke a little bit about intersectionality, and I think it's really important because it's a word we're seeing really being used actively in the changing political American landscape, but it comes directly from Black feminist theorists, and I think that's really important to honor and consider when we use that word. I also come from a social justice framework. So when we say social justice is praxis, it means how do you turn theory into practice, right? So it's not just these big, weighty concepts in your head, but they're actually ways of being in the world, how you talk to people, how you touch people, how you interact, how you organize, how you lead. So social justice as my practice, right? And this means uncovering the social, historical, political forces that limit human potential and ultimately lead to the production of injustice and inequity. And also the ethics of care framework, which is a novel feminist framework that puts forward this thinking that we tend to think of ethical and moral dilemmas through the language of justice, but there's also the language of care. And I think that's critical to nurses, to be thinking about ethics of care, right? What does it mean to not separate those two ideas of ethics being one thing and care being something else, and the worlds will not meet. But I do actually think that they're intersecting concepts in healthcare. So just to be on the same, have the same vocabulary and know that these are the common terms that are used in this work. What MMR means, or maternal mortality ratios, are the number of maternal deaths per 100,000 live births. So it's quite a big ratio, but that's what MMR means, right, in this context, not the measles, mumps, rubella vaccine. And what maternal death, how maternal death is defined by the ICD, right, which is the coding mechanisms that we use. So you can read the definition here: the death of a woman while pregnant or within 42 days after the end of her pregnancy, right, of any cause related to pregnancy or its management, but not from accidental or incidental causes. So this is how maternal death is counted. So for example, if a pregnant woman were to be in a car accident or God forbid, in a gunshot accident, that would not be considered a maternal death because it was not related to her pregnancy, right? And the reality is that about 90% of maternal deaths are preventable. So that is a pretty jarring number. I also want us to consider severe maternal morbidity, SMM, which are an unintended outcomes of processes of labor and delivery that result in short or long-term consequences to women's health. So these are the women who are pregnant and really sick or really ill. So these rates are similar to MMR rates throughout globally, and global health communities and public health communities and maternal health communities are really starting to give valid attention to severe maternal morbidity, because that's sort of the precursor to the mortality. So I also want us to be thinking about that. What are those things? Cardiomyopathy, pulmonary embolisms, or amniotic fluid embolisms, or postpartum hemorrhage, eclampsia, sepsis. These are all things. And I want us to also be thinking about where the U.S. as a part of the global community, right? So when we think of global health, we don't often think of the U.S., but we are part of the globe, right? So I think it is helpful to think of our outcomes and our measures on the global landscape, right? And so that we can see that we're not doing as well as we'd like to think. We tend to think of problems in other countries, in low and middle income countries, but this is a very clear indicator that we are not doing well on our maternal health indicator. So you can see the U.S. Maternal health and the MMR rates are rising in the U.S. You can see by this graph compared to the other high-income countries. These are just high-income countries. We have the highest MMR of any high-resource countries. We rank 30 out of 31. Of the high-income listed countries, 31 is Mexico. And among the 8 countries in the world that are experiencing increasing maternal death rates, we are among the 8 other countries. So it's really, I think, good to think about it this way, right? Not to think about it in an isolationist way. right? And let's think about just giving us a sense of maternal child health in general in the US. So we know that pregnancy and pregnancy related conditions like labor and birth, antepartum conditions are the most common reason for hospitalizations, the number one reason. It's 23% of all hospital stays. It's the most billable item in the hospital. So it's something important to think about. It really is a driver of the hospital economy, right? And pregnancy-related mortality and morbidity disproportionately affect women living in poverty. And I would add to that women of color, right? We know that that is true. That is true. And of women of color, it's Black women that are facing the disproportionate effects of maternal-related mortality and morbidity. The consequences of this, the clinical consequences, are high infant mortality rates, high rates of preterm birth, high low birth weights in terms of the infant health outcomes of these things, right? So with maternal child health, we consider both. We consider the mom and the infant, right? They're a dyad for during the pregnancy and even after the pregnancy. So we tend to look at these infant outcomes as proxies for measure of quality. So just something to think about, right? And we know there's a growing body of work that's showing that it's the structural and systemic failures of our systems that are at the root causes of these high rates of mortality and morbidity for women living in poverty and women of color. These statistics, I think, have become kind of common vocabulary because of the work by ProPublica and NPR on this maternal health issue. The recent report with Serena Williams, what happened to her through her pregnancy. So it's really becoming common that people are able to cite this statistic, right? That we know that in the US, Black non-Hispanic women are 3 to 4 times more likely than their white counterparts to die from a pregnancy-related condition. In New York City, that statistic is more glaring. Black non-Hispanic women are 12 times more likely than white non-Hispanic women to die from pregnancy-related causes. This is older data, it's from 2013, but hopefully at this point you figured out that data takes a long time to catch up to current time, right? So in New York City, we see some real glaring differences compared to the national averages, and there are geographic locations where you see more acute conditions. And if I was there, I would ask the students to think about what areas they might think would have these kind of glaring conditions. They tend to be the very urban areas or the very sort of rural and remote areas. And there are certain states in the US that suffer the worst of the outcomes. They tend to be in the South. So states like Texas and Georgia, Alabama tend to have pretty poor maternal health outcomes, right? And we just again, to reiterate, this also affects infants. So what are the conditions? What are the conditions leading to morbidity and mortality, right? I just wanted to give you a visual idea of what those conditions are. What are women dying from? A lot of students ask me, what is it? So this just gives you a snapshot. It's mostly related to hemorrhage and pre-existing conditions that are made worse by pregnancy, right? But I would say in the US, for us, it's mostly related to severe bleeding or hemorrhage and preeclampsia and eclamptic conditions related to high blood pressure or hypertensive conditions. What makes us different? And again, if I was there, I would love to hear your thoughts on what makes us different than all the other countries, right? Why are we so low amongst the high-income countries? And what's different about us in comparison to those countries, right? So these are some proven proven categories, and you're going to see my own personal bias as to what I think makes the U.S. different. So we have a lack of universal health care, right? Health insurance and health care is not guaranteed for a human being in the United States, regardless of your your immigrant status, right? You're not guaranteed health care, right? We have tremendous racial inequity in the U.S., and this obviously leads to racial health disparities. And I think the third major difference between the US and the other high income countries is a lack of an integrated midwifery care system. We don't have that in the US. It's very uncommon in the US. So in the US, our rate of babies who are being caught by midwives is hovers around 9%. You can look at other countries that have better maternal health outcomes, and theirs hover around 40 to 50%. So it's quite a big difference. So these are the three sort of main domains, I think, that set the US apart. And what else we can talk about in terms of the US in relation to other countries is this idea, and I've abbreviated it here, is TLTL, too little, too late, and TMTS, too much, too soon, right? So we most would say that the US has both of these factors at play, right? That it would be a gross generalization to say that too little, too late only happens in low-income countries, because there are many communities in the US that don't have access to emergency maternity services. So there are many counties, for example, in New York State, where women have to commute for about 2 hours to reach any kind of basic emergency maternity care services. That would be a situation of too little, too late. Too much, too soon is usually associated with high-income countries like the US, where we're delivering too many interventions too soon, too often, right? So that could be something that we could say is something that the US healthcare system is guilty of, right? A lot of interventive practices, a lot of technology, overdiagnosing, overuse of diagnostic tools. Those are all things to think about. And again, if I was there, I would really love to hear some of your thoughts and ideas of how you see these ideas playing out of too little, too late, and too much, too soon. So for example, for too little, too late, I can think of examples in my own clinical practice of someone without health insurance maybe arriving to the ER because they're that acute that is the only health care access that they have, right? And it might be what we are able to give them is too little and too late because they're just so acute. Too much too soon is, for example, maybe offering elective cesareans is maybe too much too soon, right? So offering this very intensive surgical procedure without a medical indication would be an example of too much too soon. And I would ask us to look at it through the lens of cesarean birth as an example, right? So we know that there are disparate rates between and within countries and between and within states. So you can go, for example, to a hospital in Brooklyn, a no-name public hospital with a strong midwifery service where this primary C-section rate might be 18%. And you could go to a very wealthy, well-endowed private hospital in New York City where the primary C-section rate is 40%. So you're seeing within a 3-mile radius a really large difference in terms of cesarean rates, right? You might see higher rates in private practice, higher rates in, like I said, in wealthier communities. So these are things to be thinking about. This is just an example of what's too much too soon, right? Looking at our cesarean rate, the U.S. cesarean rate hovers around 33% versus the global rate. It is definitely something to think about. Are we offering too many interventions, right? And we also know that Black women have higher C-section rates than their white counterparts. So these are things that are affecting women of color very directly. And then moving on to the racial health disparities in terms of maternal health as the root causes of health, right? So we know, and I think you talked about this in your prior lecture, that inequality and discrimination that are perpetuated by historical structures and institutions are really have to be considered and dismantled actively to address some of these root causes. Low socioeconomic power and political power held by women leads to, we know, this is for sure in many parts of a person's life, less access to education, less personal income, less control over their fertility, If you don't have healthcare insurance, you may be less likely to seek out contraceptive care. That's a significant expense for a person, right? We know that there are social cultural practices within certain groups that need to be considered. I can say, for example, if you come from a culture that is patriarchal culture, that this has to be considered, right, in terms of how the social dynamics of maternal health are shaped, right? And I really want to focus on this idea of blaming the person and not the system. I think this is a root cause of social sort of disease of the healthcare system, is that we tend to blame the person and not the system. So with someone who might have diabetes, we tend to blame the individual, right? Not the system that she's living within, or whether she has access to, whether she has food security or housing security. Those are questions that we don't ask in our normal day-to-day health intake. But if someone has food insecurity and housing insecurity, so let's say, for example, a pregnant mom with 2 children is living in the shelter, food insecurity and housing insecurity are very much going to contribute to her ability to eat and her ability to make choices for herself and her children. So that is the way we need to think about the system versus the person. And so overall, we know that we have unacceptable rates of mortality and morbidity for pregnant women. And there are long-term and psychosocial outcomes are generally overlooked in these settings, right? We tend to think very clinically, very bedside. It's very important, obviously, but we don't often see a person coming into the healthcare system as an opportunity to look at the full scope of their lives, right? We know that the U.S. has had very high rates of unnecessary interventions that tend to be, especially in maternal health, tend to be Black women do have the highest rates of interventions. We're talking about C-sections and inductions. So that is something that we need to more closely examine. We know that there are inequalities in outcomes and quality is something that we're going to talk about soon. And I do want to also point out these other kind of softer concepts that we tend to not think about in healthcare. That care and compassion are seen as less important, usually because they're not measurable, but they're integral to system failures, right? So when we talk about communicating with patients, communicating with families, recognizing cultural norms, not perpetuating, for example, heteronormative ideas, these are all things that we need to be thinking about and not to be thinking about as soft skills, right? But these are really integral to how people interact with the system, right? And if the system fails them, they're less likely to seek out help in that system. I think that's something we need to think about when we think about, maybe you've heard the term a non-compliant patient. It's one of my pet peeves, right? What are the system failures there? If you could conceptualize some of the system failures of this kind of idea of a non-compliant patient, what does that mean, right? And then again, this other idea of disrespect and abuse of women within the health system, and not just of women. I would say any sort of historically disenfranchised group, right? We could talk about the trans community, the LGBTQ community, immigrant communities, so many that are historically disenfranchised because of a lack of understanding within the system of these groups. It can lead to moments of disrespect and abuse. So these are all things that we need to be thinking about very actively, whether it be at the bedside or whether it be nurses who are very politically active or active in lobbying organizations or nursing organizations. So you can think about these ideas on a range of your function as a nurse. And what has to change? Again, if I was there, I would love to have this conversation with all of you as a group, but what has to change? So I want to sort of end with these ideas of quality. What is quality maternal health care, right? And the WHO, the World Health Organization, has created this framework for quality maternal care. And if you look on the far left, you'll see these three bigger domains of structure, process, and outcome, right? That we have to be thinking about these three sort of big domains. And then we start to think about sort of an ecological view, right? What's the big system? How do we look at all of these dimensions of healthcare and think about where changes need to happen, where we need to focus our attention, funding, policies, training. So these are things to think about. And this wasn't always the case, right? We always tend to think of quality, we think of what are the outcomes? You know, do we have fewer NICU admissions? Do we have fewer C-section rates? Do we have fewer episiotomy rates? But really, healthcare thinkers are realizing that the giving of care and the receiving of care are really what create the quality of care, right? So giving of care, are we using evidence-based practice? Are we using, when they say actionable information systems, are we using systems that are dynamic, right? Are there functional referral systems in place? And then the experience of care. What is it like to be in the system of care, not just as a patient, but also as a provider in terms of communication, respect, dignity, emotional support? Are there enough providers? Are there enough resources? You know, things like that. Even, there was recently an IV shortage after the Hurricane Maria in Puerto Rico, because they provided the IVs for the H&H hospitals, the public hospitals here in New York City. So thinking about things like that. And then also obviously thinking about the individual and facility level outcomes. So that whole chunk of quality was not there usually. It went right from health system to individual and facility level outcomes. So I think it's really, really important to look at the whole picture. And then this is another quality framework that I want us to be thinking about. We're going to operationalize this in our little activity. So this is the 4 domains for providing effective sexual, reproductive, maternal, and newborn health. That's SRMNH, sort of a mouthful there, right? So looking at sort of these broader domains, right? And they're very reluctant to define these for people because we realize that contexts are really critical to shaping policy and programming. So each context is different. So what might work in my hospital in New York City may not work in a hospital in Arkansas, right? A smaller community-based hospital in Arkansas or a regional hospital in Tanzania, right? So, but the concepts are key for all humans, right? Looking at availability, looking at accessibility, looking at acceptability, and looking at quality. How you define those things, again, will change in terms of the context that you're in. So I do want you to think these through in your own way. What does it mean to have available maternal health care services, right? That could be availability could mean basic services that you just have a hospital within an hour, or availability could be having, like, for example, for an Orthodox woman to have a female provider could be really important, and the availability of that could really shape her experience of care, right? Accessible, right? Are your services accessible, right? So for a woman who has 3 kids and works a full-time job, do you have clinic at night, right? Or does she need to take a day off from work? And then you wonder why she's missing prenatal visits, right? So that could be how you define accessibility. Acceptability, right? What's acceptable in terms of the maternal health care services that you're providing, right? What is acceptable? And quality. So again, really broad terms here. Quality can mean a lot of things to a lot of different people. So I'm not going to go forth and define that for you, but you could use the framework, the WHO quality maternal newborn framework that we just reviewed in terms of quality. And I do want to, because that was my third bullet point on what makes the U.S. different, talk to you, and I do a little sort of self-promotion of midwifery care, right? So thinking about how do we start to integrate midwifery care into maternal health care services, I do think is a big system-wide shift that I'm hoping that this country will be moving towards. Right, we know the impact of midwifery care. You can reach more women, you can provide more services, You can support physiologic processes. That's how we're trained, right? With the judicious use of intervention. And you can begin to task shift, right? You can provide skills and supportive and preventative care by other types of providers, well-trained, highly skilled providers, right? So just rounding down this lecture, or is that right? Rounding out this lecture, right? Thinking about what are pathways to creating healthier maternal health care systems, right? These are just some ideas that I put on the page, just to be thinking about some of what has come up here. But what does it mean to prevent and promote health? What does it mean to have community-based health, right? What does it mean to have collaborative care, right? And what does it mean in communities where we know that, for example, that Black women do suffer the worst of the maternal health outcomes? Why are we not doing better psychosocial risk assessments when we know that historical disenfranchisement can very literally lead to poor health outcomes? We need to be doing more psychosocial risk assessments and really engaging people in those parts of their life and shifting our approaches, right? So shifting from mortality to health and well-being, from focusing how we do our research, looking at what the experience of women is giving the care, what's the experience of nurses working in certain communities versus only focusing on RCTs of specific interventions, right? So I don't mean to put them in opposite factions. I think we need both. I think we need all of these types of data. And focusing on systems. Again, I'm really wanting to drive home this point of not blaming the person, but really deconstructing the system, right? Looking at ideas of the workforce, is there enough nurse staffing, costs, resources. These are all really important in terms of shifting our perspective on improving maternal health outcomes. And just just thoughts on foundations of changing our vision, right? Of just sort of, these are all ideas that are not my own, right? These are just ideas that I've culled from different sources. What do we really need to change our vision and to improve maternal health of all women, right? Really women living in poverty and women of color are not getting what they need. Our maternal mortality rate should not be rising. So what do we need to do to change our vision of a more equitable maternal health care system, right? So these are some ideas towards that, and maybe some of you have more ideas that you can contribute. So just as an exercise to think this through, and this is the end of my talk, I want each group, I'm going to ask that you divide into groups, and each group is going to be assigned one of these domains of the UNFPA domains, quality domains, right? So availability, accessibility, acceptability, and quality. And I don't want you to get hung up on the definitions of these, right? Because again, UNFPA has created really open and porous definitions. I want you to consider the various aspects of whatever domain that you were assigned to, and you want to interpret them in whatever way you want in relation to maternal health care. So you could even imagine a particular patient or a particular community, or a particular population of people that you're familiar with or you have worked with, who may be historically disenfranchised. And I want you to determine 3 issues related to each of those domains. You can use your imagination. There's really no right answer here. Just imagine what kinds of issues women, families, people might encounter related to availability or might encounter related to acceptability. And then for each of those 3 issues, I want you to suggest 3 nursing actions you could envision in response to these issues. And allow yourself to think local or global. And by that I mean you can think close to the bedside. That's what I think of as local. Or you can think global. You can think of creating a program or thinking about creating a policy or thinking about designing a protest or something like that. You can think global too. right? So just to give you an example, if you got assigned quality and you want to be thinking about issues related to quality maternal health, these might be 3 issues that you might come up with on your own, and then I want you to, as a team, design some nursing actions, right? Again, there are no right answers here. It's really just a way to just get your mind around these concepts and see how broad nursing care really can potentially be. So again, thank you so much for your time. I haven't done many recorded lectures, so I hope this was okay and the quality was good and you're able to flow and follow through. This is my email and my Twitter. I mostly tweet about maternal health issues, so if you're interested, please follow me. And here are some references if you're interested. Thank you so much, and I hope you have a great day. And if any of you are interested in these issues or topics, midwifery, global health, intersectionality, feminist theory, whatever, anything on here that really struck a chord, please feel free to reach out and email. Thank you so much.